Okay, thank you all. It's not often that we get to have people that have a skill that is so far outside of what most physicians do in the world, but today we've got somebody who is actually a friend for the last 30 years, who also impersonates a race car driver as part of his hobbies. And he's out at Dakota today, the Circuit of the Americas racing, and was able to come and participate here. And I thought, because Bruce Myers is a physiatrist who deals with these exact same issues in New Hampshire, which has the highest or one of the highest addiction rates, and pain is such a big part of that too. I thought it'd be good to get a perspective from that part of the country. And Bruce is also one of the few people that I can say in this room or almost anywhere that is actually a groupie of mine. Prior life, I was lead guitarist in a blues band, and he and his wife followed us all over the place. So, we're going to go ahead and get started with Bruce, and then we're going to have David Browder join us after that. David is a physical therapist, PhD trained, with an organization called Texas Physical Therapy Specialists. And he belongs to an organization that's nationwide called Evidence in Motion, which I think he'll have a chance to tell you more about it, but it's a ongoing continuing education program for PhD level physical therapists who can stay current on the evidence-based approaches, really with a deep immersion in the neurocognitive sciences that have to do about pain and substance use, and they take on those issues straight ahead and deal with them in a way that many physical therapy organizations have not really come to grips with. So let's go ahead and have Bruce start, and we'll get going. Bruce has to leave because he's got a race coming up, so we're going to get him done early.
Thank you, Dan. Well, this is a kind of a talk on addiction and just say no to auto racing because it's highly addictive. It's really, really addictive. I have been practicing physiatry for about 30 years up in New Hampshire, and I'm sure that you've heard our president call New Hampshire a not so nice, I can't remember exactly what he called, but New Hampshire is the highest rate of death per capita from overdoses in the country. And New Hampshire is also one of the most affluent states in the country. So it is addiction, opioid addiction and deaths are not at all, they don't correlate to just, low socioeconomic individuals. So I practiced, when I came out of residency in 1989, I didn't practice the way I practiced 10 years ago when we were told that we had to treat pain as the fifth vital sign. So who here knows what a physiatrist is? All right, about half. So just so you know that we're not psychiatrists, although psychiatrists are great, but physiatrists are non-surgical physicians. We come out with expertise in soft tissue medicine, neuromuscular disorders, and I have a strong interest in the non-surgical, almost sports medicine and neuromuscular, but it goes into physiatrists treat brain injury, they treat strokes, they treat spinal cord injuries, and physiatry started in 1947. Basically, when people came back from World War II, because of the advent of antibiotics, they came back alive with a lot of disabling injuries and nobody knew how to manage them. So at Rusk, physiatry started, and in the 70s it kind of ventured into the musculoskeletal realm because the orthopedic surgeons weren't managing a lot of the disabilities very well. So I trained at the University of Wisconsin in Madison, and where Dan also trained. And we I came out with a very strong interest in treating musculoskeletal injuries, which means I treat pain. But we look at pretty much everything. And the way I treated patients in 1989 when I came out was to really evaluate patients thoroughly, so you try to get a good diagnosis. And which way is forward on that? Let's go backwards. All right. So I take a long time to evaluate patients. We typically see a new patient in an hour, which is really rare. But I also run my own practice, and I can dictate how much time I want to spend with patients. Most physiatry practices now are owned by hospitals or are in big groups. They get a half an hour to 45 minutes to see a new patient. When you have a complex patient coming in, you can't do it in a half an hour or 45 minutes. And this is one of the issues with the way modern medicine is right now. I make less money because I see fewer patients a day. And so we evaluate things. We do a very thorough history. We evaluate all the previous labs and all the previous studies that have been done and try to come up with an appropriate diagnosis. Because from my standpoint, having the right diagnosis, it allows you to treat the patient very effectively. If you don't have a very good diagnosis, then you're sending them out and doing different techniques and different procedures on them just to see what the diagnosis is. And so we try to spend a lot of time really defining what we're treating. And to do that is an art. You don't learn that necessarily in medical school. And if you're really lucky, you have a really good mentor like I did, you learn it in residency to some degree. But a lot of physicians, you have to learn that on the job, and it takes time. When I started in 1989, I did not prescribe narcotics except for acute pain, and then only a small number. 15 years later, OxyContin comes out. Oh, it's a great drug. It's not addictive. You know, you can treat people with pain, and we had to use pain as the fifth vital sign, so everybody started prescribing narcotics for chronic pain because chronic pain was perceived as the same as cancer pain. Well, fast forward 10 years, and now we have the problems that we're having now, and I think it's fairly high percentage of narcotic abuse and heroin users started with prescription meds. And it's affected my family. I bet in this room, at least half of you have somebody you know that has been affected by the opioid crisis. And it's pretty hard because I just had something happen to my family within the last week, which is like, it's not supposed to happen to you, but it did. So we analyzed the mechanism of injury. We spent a lot of time talking about mechanism of injury, and it really helps guide treatment. So what we do is we practice in a multidisciplinary fashion. So we use pharmacological methods, but it's predominantly non-narcotic, non-steroidal anti-inflammatories, acetaminophen, muscle relaxers, neuroleptic medications like gabapentin, Lyrica, and we try to treat the patients physically through PT, OT, speech. We do all kinds of non-traditional types of treatments. I do acupuncture. I have been the medical director of Portsmouth Regional Hospital for 30 years, and we have a very experienced rehab staff, and they do Pilates, they do yoga, they do manual therapy. I have 2 osteopathic physicians in my practice. So we really hit every way of treating them. I do musculoskeletal ultrasound, which is a great, inexpensive way of diagnosing soft tissue injuries. It's just come out as it's supposed to now be the first line of diagnosis for rotator cuff injuries and shoulder injuries instead of MRIs. And, you know, we're dealing with exponential increases in cost of medicine. I don't know about you folks, but my personal health insurance went up 14% this year, and that's a group. So we can't sustain that. So ultrasound's 1/7 the cost of an MRI. So anything that we can do to try to reduce the cost of diagnostics would really help. So my approach in our practice is that we're involved in a local spine clinic, and it's really a virtual spine clinic. It's not a mortar and pestle, I mean, a mortarized building, but we're the physiatry group. There's a pain management group and an orthopedic group that takes place, that is involved in the spine group. And we have a nurse that does all the intakes. Then the chart goes to an orthopedic surgeon. That orthopedic surgeon decides which specialty should actually see the patient. And about 80% of the patients come to physiatry. The only problem with that is that there aren't that many physiatrists in the country. There's about 5,000 of us compared to 100,000 or more, probably 200,000 orthopedic surgeons. But that's how the spine clinic evaluates. Then there's also the pain clinics. And I don't know if people are really familiar with the difference between a spine clinic and a pain clinic. But a spine clinic is multidisciplinary. And a pain clinic is either run by usually an anesthesiologist or a physiatrist specializing in spinal injections and procedures. And now a lot of radiologists, interventional radiologists are doing it. So in the spine clinic, we have this methodology of how to find people the best path to getting them healthy. A lot of the spine conditions that come in through the spine clinic are chronic back pain, and they've been treated before. So we have to find new methods of treating them. It is a very effective way of treating spine and spinal injuries, and about 50% of chronic pain is spine related. So we do use a lot of different modalities. I mean, specialists, physical therapy, occupational therapy, psychology, because most of these people have chronic pain. They do have depression that often goes along with it, as well as anxiety. In the pain clinic, it's a little bit more focused in terms of procedures, and they sometimes will have a psychologist working with them. There is a great majority of these spine clinics kind of blew up with the advent of oxycodone and OxyContin being prescribed, and now they've even gotten more popular because a lot of practices in our area are not prescribing narcotics anymore. And so all these patients are now going to the pain clinic, and the pain clinics, you know, the anesthesiologists who run pain clinics aren't really trained in musculoskeletal evaluation, but they're very good at doing procedures. So you can sometimes get into this procedural vortex, as I call it, and where they diagnose by finding out which procedure works. So it's very expensive. Single spinal epidural steroid injection is about $1,500. So these clinics, although can be effective, they can also be very expensive. And they also put in spinal cord stimulators, which run on the order of $35,000 to $100,000. And these spinal cord stimulators are designed to break the pathway of pain to the brain from the location of injury. And I often get patients referred to me to see if they're candidates for spinal cord stimulators, and I probably suggest maybe 1 in 10 really is, because a lot of these people have just never found what their pain generator is, and once you find out what the pain generator is, if you treat it correctly, a lot of times they don't need the spinal cord stimulators. On the other hand, spinal cord stimulators, if effective, can really reduce narcotic use. So our goals are to find the correct diagnosis, treat that problem as best you can, not using narcotics. We have basically gone back to the way I practiced 30 years ago, and that is to treat with physical modalities, education, changing people's way of life, getting them to adapt to, if they do have permanent disorders, permanent disability, or permanent limitations, getting them to accept that and not keep looking for ways to resolve it, and really become an effective person and a functional person in society again. And then many times we'll actually try to reduce their narcotics or actually get them off narcotics. I would have to say that at least 80% of the patients that I have gotten off narcotics 3 weeks later have no more pain than they had when they were taking their narcotics. Because within 3 or 4 weeks of taking narcotics, your body habituates to it anyway, and you really aren't treating pain anymore. You're getting the psychological benefit of the narcotic. So, you know, once we kind of changed our way of practicing back to the way I used to practice, we lost 5% of our population because we either referred them to a pain clinic that continued their narcotics if they failed the taper, or they don't get sent to our clinic by friends who think that they can get an easy prescription for narcotics. So it's made actually our practice a little bit more fun and enjoyable, and I think we get a lot of motivated people. Now I live in Portsmouth, New Hampshire, which is Seacoast, New Hampshire, and it's a pretty affluent community, but I'm amazed at how many affluent people get hooked on narcotics. And much of it is because they want an instant fix. You know, they don't really want to work through the issues here. Of the 3 people sitting here, all of us have had, you know, injuries which 15 years ago people would have been put on narcotics for. And all 3 of us, right, are functioning. And, well, at least 2 of us are functioning anyway. I'm not telling. So, you know, it isn't always easy, but that's how, as a physiatrist, that's how I practice. And, you know, I really apologize that I have to run off, but I will be here later today, and I'll be at the get-together tonight if people have more questions and want to talk about some of the stuff that we're doing with the pain clinic up there. But thank you.